colorectal gecko session, which is being recorded. Gecko is hosted by the Gastro Foundation in association with Project ECHO of the University of New Mexico. And Gecko Fellows meetings run every week on Monday at 4:30. And once a month, those meetings are colorectal in nature. And today we'll be talking about preparing the Crohn's patient for surgery. And in the library, you can see Mohammed Etleb and Voya Soldati. It's two of the Hrudiskir Fellows who are both, well, Voya is going to be presenting a patient today, and we'll be discussing some of the aspects around this patient. I encourage you guys to please interrupt and ask questions. Just put your hand up or shout, that's quite fine. And ask a question if you've got one, because often if you wait till the end to ask a question, you'll have forgotten it, we'll have forgotten the answer. So just get in there and let's try and make it as much of a discussion as we possibly can. All right. So Voya, would you like to just take over the screen and present your patient?
Hi Adam, sure. Let me just share my screen. Okay, is that coming across? Can you guys see that?
That is, yeah. And you can go to
slideshow presentation mode. All right, there we go. So as Adam has said, I'm one of the fellows here at Hrudiskir, and today I'll just go through a case presentation of a patient with Crohn's. Okay. So this is a case of a 31-year-old female who was actually diagnosed in 2005 with Crohn's in the private sector initially, with mostly with fistulizing and stricturing disease, small bowel and large bowel. Has got quite an extensive medical history in terms of medical management. It's been on Humira, Aspirating, infliximab, and prednisone recently. Was last admitted in March 2020, after which she defaulted treatment. So on this current admission now with diarrhea and cramps, she had not been on any treatment. Also has an extensive surgical history. A file says she's got up to 8 surgeries. Can account for 6 of those with some missing up notes because it's been quite a long time since 2011. But generally, initially she came in with perforation, had an ileocectomy with stomas, and then had small bowel obstruction, and a proximal loop ileostomy was fashioned for that. And then after that, most of the surgeries have come for other strictures, mostly a long one that was in the splenic flexure, as well as closure of her stomas, with the last operation being in 2019, where her last ileostomy, which was the last stoma she had, was closed. Rest of her medical background is that she's RBD negative, treatment for depression, and also has some fatty liver disease with an MRCP showing no PSC, and steatosis confirmed in biopsy. And she's currently smoking, 21 pack year smoker. Clinically, she's very wasted, emaciated, weight of 34, with a BMI of 14.2. Abdomen was tender on the right lower quadrant, distended but non-peritonitic. She's got all these previous scars of laps and stomas, but currently no actual stoma. And on PR, she's got some perianal fistula disease. Her last colo that we can get from the notes was done in March 2020, and that showed some strictures in the sigmoid, and as well as a terminal ileum. And also the small bowel was very inflamed with lots of ulcers. But they could pass all the areas of narrowing. Carry on. In terms of a blood workup, you can see that she's anemic at 10.2. She's got preserved renal function, albumin of 23, then elevated CRP of 124, although a white cell count remains at around 9. So in terms of a CT scan that was done on the 18th of Feb, just to summarize the findings, we had to look at the image. Basically, there were some areas of stricturing within the small bowel and large bowel, some inflammation of the anal rectal region and some perianal fistulae, and then a very prominent CBD going right down to the ampulla where they queried a periampullary mass, but at a side view and scope that showed there was nothing there. Okay, just gonna share a video now of the CT scan. So this is obviously starting from the chest, which is pretty much normal. And then you can see this large steatotic liver, which has been reported on, collapsed stomach. Looks like they actually that previous scope that showed nothing. And then if I just stop it there quickly, if you follow down from this gallbladder CBD, it's a huge CBD going all the way down to duodenum there with no mass and with an okay pancreas. She's had previous MRCPs that don't show that typical beaded appearance before PSC. Then I'm just gonna start from the bottom because it's basically how I like reading scans in colorectal. So you can see here, there's all this inflammation from the perianal fistula disease. And if you follow that up, there's all that fat stranding around the anus rectum. And then you start seeing lumen of rectum going up. I mean, I can't follow, it's tough to follow all her bowel, but you can see there sort of sigmoid, you start getting a stricture up there, and which opens up, then strictures again, then you start getting into opens, you get another stricture, then you start getting into this massively dilated bowel there. Anyway, that was as far as I was going to take you. And then when you take it, you can see there's just little areas of collapse, then mostly lots of distension. I'll let it play out again just for you guys to see. So as I've said, the liver, CBD, then you start seeing this massive bowel. I think that on top there is some of the small bowel, and then just a little bit underneath, there's a little bit of colon going through there. So she's in a poor nutritional state. She's got this massive bowel that's probably not absorbing much, diarrhea, and as I said, labs showing low albumin, low HB, high CRP. So yeah, with some active perineal disease. Okay, yeah, that's pretty much our case presentation.
All right, great. Do you want to stop sharing for the moment?
Okay.
Just let some more people into the waiting room. Okay, so I think for those of you that do the certificate exam that might be in the audience, this is the kind of scenario you'll be given in your exam, where you will get the case vignette, which will be a PDF of the results and a sort of description of the case, and then access to a scan, which you will look at and go through, and you will have to formulate a treatment plan on the basis of this, and that'll be the start of your oral. So I think could you just summarize what the problems are here and what you see as a reasonable treatment plan? I think you're muted, Vuyo. Which, when you're doing your exam, it's not a good thing.
I can say I gave the right answer while I was muted. Okay, so I think the big problem she faces here is that she's obstructed. So you can see that massively obstructed bowel with the weight loss and malabsorption. And then other issues that come with it is that there's sepsis going on. We do see that there's perineal disease. What I do know, because I know the patient, is that since then we've done an MRE that actually showed some subcutaneous abscesses as well. So there was some sepsis going on. So you've got some sepsis and you've got obstruction, and then you've got the overall picture of a patient who's just in a very poor nutritional state. So I'd say for me, those are the three big problems we're looking at: obstructions.
So if you've got a patient with Crohn's who's got obstruction, what are the two possibilities for the cause of those obstructions? Well, probably three possibilities.
Yes. Okay. So you can have a flare with like a stricture with active disease. that's causing it, or you can have a stricture that's like not part of, actually like a fibrosed kind of stricture. Those are the common causes of obstruction.
Yeah. So I think that's correct. And then you can have the situation where you've got an abscess, which is just causing an ileus and kind of causing an obstruction as well. But the abscess is usually on the basis of a flare causing it with a fistula. So they are sort of linked. But I mean, it might be that you've just got to resolve the sepsis. So I think those are kind of, and there's, I mean, is there a difference in treatment between a fibrotic stricture and an inflammatory stricture?
Yes. Yes, there's. So with an inflammatory stricture, you can have a look at trying to go for medical management, especially with the biologicals. You can actually get resolution of strictures with biological therapy. Whereas with fibrotic strictures, you're having to look at some kind of intervention, whether it's endoscopic or surgical, but you need some kind of mechanical intervention for those.
Yeah, I mean, I think that, so once your inflammation's burnt out, it becomes fibrotic at some point, and that narrowing isn't really going to change. The reality is that I think if we look at most strictures, there's an element of inflammation and an element of fibrosis. Obviously, in this patient, you've got someone who's actually had almost all treatments available to her and defaulted all of them. So before we start thinking about how you're going to try and treat her, what can she do to treat herself?
So the big thing with her would be to stop smoking. Yeah, she's still smoking, and that's gonna make things difficult for her.
Mohammed, how effective is stopping smoking treating Crohn's?
Yeah, so just to go to this patient, she's fitting all the criteria to be categorized as a high-risk patient in terms of the extent of the disease, multiple resection, perineal involvement, and smoker. Smoker is equal to the biologics in terms of treatment, and going to smoking or continuous smoking is increasing the fold of the recurrence is more than 3 folds, and she's already had a recurrence now, if you can consider as a recurrence. So yeah,
one of the ethical issues that we have, and we haven't really dealt with it, is that in a place where you've got limited resources and we've only got a certain amount of access to biologics. Now, let's not talk about this patient specifically because she's actually had all the different biologics. But can you justify giving someone a biologic if they're still smoking? Because the reality is that you're going to get almost as good an effect just by stopping smoking. And I certainly think if you've got 2 patients, one that doesn't smoke and one that does, you can really justify giving it to the one rather that doesn't smoke rather than the other. But the reality is the resource isn't that finite, and we don't often have to choose between the two. But I think it really is something that we've got to look at quite seriously in a patient like this. That she's really, as you say, she's a high-risk patient. She's got penetrating disease. She's young onset, multiple surgeries, and a smoker. So you'd want to get her, if she was treatment naive, you'd want to get her onto a biologic almost straight away. And to be honest, in this patient, you want to avoid surgery at almost all costs. The fact is, we've got very few options in this particular patient. And if she, in a way, we've got, knowing the patient, we've got multiple social issues that have resulted in her defaulting all her medication. But doing surgery for social issues almost never works. And, perhaps we need to rethink that. So, I think the first thing to just know about these patients is to identify the high-risk patients. And then, when I worked in Amsterdam, Willem Beemelman always used to say, when everything's a complete disaster, surgery is not going to be a winner. And he was always quite pro doing surgery much earlier on, not waiting until you've got a catastrophe, much like we have at the moment, and then hoping that surgery is suddenly going to save the catastrophe. Clearly, this patient's had multiple surgeries. I do get the feeling we're not backing a winner here, but it's. I think that the principles remain the same. So if we're going to try and optimize this patient for surgery, we've already, or for her treatment in any case, you've mentioned the stopping smoking. What else can we do for her to improve her outcomes from surgery if it's eventually needed?
So there's a few things we can identify that are sort of risk factors for poor outcomes for surgery in general. Now, that said, a lot of them don't have very high level evidence to show that they work, but with what we have, things that we considered, we try. So the first thing with her would be to optimize her nutrition. As I said, she's got a BMI of 14. I mean, less than 18.5 is all known as severe malnutrition. So we have to look at strategies to up her nutrition. And then which becomes a little bit of a...
Let's come back to nutrition. Okay. Tell me about some of the other things first, because nutrition is obviously a major topic here, and we'll go into that in more detail.
Okay. Second thing, as I mentioned with her, is that she's got a hemoglobin of 10. We haven't looked at her iron studies, or at least when I was compiling this, but we have since then. So this is one of the other things that you have to look at, hemoglobin, what kind of anemia it is, and try to look at if there's ways we can optimize that. And then the other thing is, you see, albumin is sort of a marker of poor outcomes, but there isn't anything to suggest that going and superficially addressing or increasing someone's albumin will now improve outcomes. So, I mean, it's something that, so you sort of have to look at an underlying thing. Here, we do know that with the high CRP, that there's probably some sepsis going on. So we sort of need to start looking at that and addressing that and see if we can get the desired response would be an increase in albumin. A lot of literature sort of looks at a number of 30 as a marker of poor post-operative outcomes. So see if we can get it up about that. But like that said, we don't know if that equals to better outcomes. But we know
so I think it's an interesting point you raise, and actually HB to me is very similar to albumin in the way we look at it, I think erroneously. So we know that patients with a low albumin have a poor outcome for all forms of surgery. Okay. And we know that if the albumin is high, you have a better outcome. But what we don't know is, does raising the albumin improve outcomes? And what we do know is that giving albumin doesn't improve outcomes at all. We know with patients with low HBs do worse. They need more blood transfusions. And if you have a blood transfusion, you'll once again do worse. We know that patients with a high HB do better. We do know that they have less blood transfusions. So that's one slight difference. But what we don't know is, does raising the HB make you do better? There's lots of data showing that, sort of retrospective and prospective cohorts, comparing two separate cohorts. But as far as I'm aware, I know Colin Knowles, if he's online, knows quite a lot about this, so perhaps he can advise us. But as far as I'm aware, the head-to-head, certainly in colorectal surgery, where I believe there's only one randomized controlled trial, hasn't shown an improvement in outcomes. We've only managed to show a decrease in blood transfusion, which is quite a useful outcome, but actually the amount of blood transfusion was very small. So does improving the HB improve your outcomes of surgery? I don't think we can say that, but there's a lot of data showing that actually just being iron deficient can make you very symptomatic, and that's unpleasant. So you've probably got the benefit of doing that. And if it's reducing transfusion requirements, that is it's a scarce resource, and that would be a benefit just on its own. So I think we can make a reasonable case to increase the iron. We know inflammatory bowel disease patients have iron deficiency anemia, and we know that gastroenterologists routinely actually give them iron, on quite a regular basis. So I think it's very reasonable to, if the patient is iron deficient, to bring that, to get the iron up, and try and improve the HB. As far as the albumin's concerned, I'm glad you mentioned it separately to nutrition. I think, as you know, albumin is not a marker of nutrition at all. So the simple data to go and look at is albumin levels in anorexic patients. And I know lots of people have been taught differently, and we all look at albumin as part of nutrition. But if you look at albumin of patients who are anorexic, who have BMIs of 11 and 10, they usually have a completely maintained albumin. It's not a marker of nutrition at all. It's an acute phase protein, and when you've got inflammation, it drops. So we like to see the albumin coming up, because it shows that the patient is getting on top of the inflammation. And I think operating on a patient who's actively inflamed usually means that they are catabolic as opposed to anabolic. We have to think about which one is which there. And we want a patient that's anabolic. If you are using all your body's resources to kind of fight an inflammation or an infection, you're not laying down protein, building muscle, you're not getting healthier, and those patients aren't going to heal well. So we know that if we can get rid of the inflammation to a large degree, the albumin will come up, and that will show us that the patient's in a position where they are going to do better. But it's a separate process to the to nutrition. Nutrition really, there's some complex markers, but really the marker is sustained weight gain. And just remember that you can put 3 kilograms onto any patient, just give them 3 liters of fluid. That doesn't mean that they're in a better nutritional state. In fact, they're probably slightly worse off. So it has to be a sustained weight gain over a period of time. Well, what would you use as your marker of a patient being nutritionally vulnerable? How would you assess someone to say, I'm worried about this patient's nutrition and I'm going to want to try and optimize them preoperatively because of the poor nutritional state?
Yeah. So I'll start by saying I'm not sure if that's a specific technical term you're talking about, or you're just describing someone whose nutrition I'm worried about. But for me,
who are you going to give hyperalimentation to?
Yes.
Who are you going to intervene nutritionally
Okay.
on?
I see, absolutely. So I think it's the people who, so there's 2 groups. There's those who are severely malnourished, so who have BMIs less than 18.5, they're worried about. And then there's this high risk group that Mohammed speaks of as well. So patients with complex disease of perforating, obstructions, and have recently lost more than 10% of their weight. So those are the groups.
I think, just to interrupt you, I mean, whatever guidelines are, that it's 10% of weight loss within the last 3 to 6 months. Okay. I'm a little bit hesitant about the 18.5. You get some BMI. I mean, you're right in principle. They certainly don't have much to lose, but it's, you get some people that are thin. Yeah. And they have a BMI of 18.5. If you've had a BMI of 18.5 for the last 10 years, then I'm not that worried about you, But, clearly you don't have a lot of resource to use. You don't have a lot of, if your BMI is that low, you probably don't have a lot of fat that you can burn if you need it. So you are potentially more vulnerable, but I'm much more interested in weight loss in the last time. And why it's particularly important in Crohn's disease specifically, I think, is because the nature of the illness means that patients tend to adjust their diet. As you get the stenosis, either caused by inflammation or fibrosis, they start cramping. And they move on to a liquid diet, slowly change their diet more and more and more until they're actually often quite far down the line before they present to us. So a patient who's been cramping and adjusting for quite some time often lost 10% of their weight. And I mean, and you'll know from the wards we work in that, 10%, 60 kilogram person losing 6 kilograms, that's common. I mean, we see 12 kilograms quite often. And so these patients, increasingly, I think we're alert to the fact that they do very badly with surgery. Now, the data is not great that improving their nutrition makes, once again, we're faced with the same thing with the HB and the albumin. We know that patients that are malnourished do badly. We know that patients that are well-nourished do badly, but does taking the malnourished patient to well-nourished, do they do well? Intuitively, yes, but some great errors have been made when we just use intuition in medicine, which is why we kind of tend to base these kind of decisions on randomized controlled trials, and we don't have any to base it on. So, but we do have an increasing data set of kind of fairly low-level evidence saying that preoperative optimization, hyperalimentation is beneficial. So, Voya, let me take it to now. So, let's take not this particular patient. Let's just take a patient in general. What are your options for, you decide they've lost more than 10% of their weight loss, you want to give them hyperalimentation of some sort. What are your options and what are the benefits of doing various things? So how are you going to go about optimizing their nutrition?
Okay, so you can have enteral route or parenteral route. And then in terms of enteral route, you can look at like a very specific strict diet, like exclusive enteral nutrition, or adding these supplements that we use for nutrition to standard ward diet, or in a patient, and that's really your first goal, is to try go enteral. But in patients where, like this patient, they massively dilated, you're not too sure if you're going to win enteral, then
You're giving me three options here. You've got basically, you give the patient TPN, you give the patient exclusive enteral nutrition, or you can give them supplements.
Yes, on top of their normal diet, you give.
So what kind of patient do you think would be a good patient to just be given supplements on top of their normal diet?
So someone who's not obstructed, obviously. You want someone who's able to tolerate a full diet, eats well, has got good absorption, well, decent absorption, I guess, part of the disease.
Let's say I had a patient that had a weight loss of 6 kilograms, so just on 10%, and had a normal CRP and had adjusted their eating pattern quite a lot lately for mild cramps and was due to have surgery in a couple of weeks' time. Normal CRP, albumin's okay. What regime would you give them?
It's a tough one because they would tolerate adding supplements to a normal diet, but then,
Well, I think that's a great, that's the scenario where you're really going to, the patient's got minor symptoms, they've just cut out a lot of food because they're struggling to get it in. So now you're going to have, in between meal times, you're going to give them milkshakes that are, and they'll hopefully have enough to just build themselves up. They've actually, the only reason why they lost weight is because they've actually put themselves on a diet. And so you're just trying to counteract the diet. Why do I mention the CRP in these patients particularly? So let's put it another way. So now you've got the same patient, 6 kilograms of weight loss, bit of cramping and diarrhea, CRP's sort of 30 odd, and albumin's a bit down. What would you think about, what about the possibilities for this patient? What would you think would be a good way of optimizing them enterally?
Okay, you see, now that you've gone like that, you're making me overthink. I don't know if I'm missing anything. It feels like Mohammed wants to answer.
Yeah, so CRP, that's mean a patient there's some sort of active inflammation. And the reason for this, you don't want to operate in one with an active inflammation. And we have poor evidence that exclusive enteral nutrition can induce a remission. So I think in this scenario, the CRP high, I would put her in exclusive internal nutrition, so we can get the albumin up, CRP down, we're feeling better, not in active, in a relapse.
That's exactly right. That's where I was sort of going with this. Just for those of you, we've just had our third fellow walk into the room. So Zubair, say hello. He's fresh out of theatre, and thinks if he sits right at the back, he won't get asked a question. Got bad news for him. Anyway, so what we're getting at, and hopefully everyone's aware of it, that there's this concept of exclusive enteral nutrition. So if you feed someone, you don't actually through a nasogastric tube, but if you feed them exclusively enterally, they will, you actually reduce the level of inflammation. So you can induce remission of Crohn's by putting someone on enteral nutrition. And in fact, in pediatric Crohn's, that is in the treatment of pediatric patients with Crohn's, that's the first line therapy for inducing remission. So instead of using steroids like we would do with the patient with the flare, you induce remission with exclusive enteral nutrition. So I think we can say that we've got very good evidence that exclusive enteral nutrition works and can induce remission. I mean, there's a lot of case series showing that that actually does. The question is, when do you use it? To use it in this scenario to pre-optimize someone, and I think the data isn't as good, but we've extrapolated that treating the inflammation, getting people to put on weight, to creating someone who's anabolic as opposed to catabolic is going to have a positive outcome. And there are data sets that show that to be the case. However, it's always a group of patients looked at retrospectively or prospectively, but not randomized to one treatment or the other, and comparing the two groups. And obviously we know that that gives you a huge, there's a huge potential for bias on the basis of selection bias. And that, the patients that didn't go for hyperelementation were sicker perhaps and had to go straight to theatre. So one of the issues that we have with this, is now, okay, so we've discussed the patient we're just going to give supplements to. We've discussed the patient we're going to give exclusive enteral nutrition to. Who would you not give exclusive enteral nutrition to? So who's the group that get TPN? Well, if you're going to do preoperative nutritional intervention.
So this group that's like bad obstruction, quite distended, there's not going to be much absorption going on there. So you want to go for a current weight.
And I think that if you cast your mind back to the scan that Will showed us, even a patient is relatively asymptomatic, because sometimes these Crohn's patients are actually quite obstructed and not very symptomatic. I mean, this particular patient doesn't complain of a lot of cramping. In fact, her complaint is diarrhea. But if you look at her bowel, it's massively dilated. And when you have dilated bowel like that, it's hugely inefficient, because what you're dealing with is a lumen like this that's got this massive amount of content in it, but very little of the content is in contact with the villi. So you're not absorbing what's in the lumen. And it's a very inefficient bowel. So if you see a patient with dilated X-ray, with dilated bowel on X-ray or CT scan, their gut will not be working properly. So we use abdominal X-rays quite a lot just as a screening test. You see someone who's got lots of loops, not the odd little loop of dilated bowel, you probably get away with that. The moment you've got massively dilated bowel, you're not going to get away with exclusive enteral nutrition or even just nasogastric feeds and eating. You're going to need to intervene with parenteral nutrition. Sometimes the patient will settle on TPN and you can then convert them to exclusive enteral nutrition. But while the bowel is dilated, I don't think that there's much hope for that. So this patient clearly is not a candidate for supplements. Exclusive enteral nutrition isn't going to help. And in fact, as you alluded to, there is sepsis on board, which we need to sort out. So in order to optimize her, we've got to get on top of the sepsis, which might just be treating with antibiotics or percutaneous drainage. And we're going to give a TPN. Whether you're using exclusive enteral nutrition or TPN, Mohammed, what would you, for how long? When are you, just until you feel better? What's your target?
So we don't have exactly like something we can predict in this patient, but the entire point that we need to get them in an anabolic phase. So if the inflammatory markers start coming down, albumin start coming up, that we are on top of the infection, and they start getting weight. So usually we can see that from 2 weeks time. Yeah, I would say 2 weeks. It should show us in a laboratory result there's improvement in terms of the CRP, albumin, white cell count, and the weight.
Yeah, I agree with you. I think that it's more, the 2 weeks, essentially you can't do it for less than 2 weeks because no one can put on weight in less than 2 weeks, not a measurable amount of weight. So 2 weeks is going to be your minimum. I mean, any weight you put on in the first couple of days, you'll be very alert to fluid balance. You put someone on TPN, they put on weight instantly because they're actually getting quite a bit more fluid. So I think a minimum of 2 weeks, but you want to see things changing. So you want to see that CRP come down, the albumin going up. You want to see the weight climbing steadily over a period of time. And so 2 weeks, it becomes a focus in our mind. I think the important thing is a minimum of 2 weeks. And clearly that's one of the problems with intervening like this is that it's quite a high resource intervention, admitting patients for 2 weeks, sometimes 3-4 weeks to hospital. You can imagine if you had to, if that was your life, what chaos that causes in your life to suddenly be in hospital for a month and then have an operation and then recover from the operation before you go home. So it's not something to just be done at the drop of a hat, but saying that we know that if you look at big data sets, IBD independently predicts poor outcome. And I think largely that's because Crohn's patients are often nutritionally vulnerable, and they're often in a pro-inflammatory state, and we've got to try and turn all of that off. So yeah, I mean, I think in this patient, so our plan for this patient is to give her a proximal stoma again, because we've done it before, and we can get most of her disease distal to it, which will quieten down that disease. And when she had a stoma above all of her disease previously, it was the only time that she was doing really well. She'd put on a lot of weight with the stoma, and she eventually convinced us to close it because her disease was actually under control. But we had our doubts, and I think our doubts have been vindicated. So I'm sure that some of you in the audience are thinking, but you're just bringing out a stoma. I mean, just go ahead and bring it out. Why are you going to admit this patient to hospital beforehand and keep her in hospital for a month, all the risks of TPN, line sepsis, et cetera, when it's not actually going to get an anastomosis? Why don't you just take her to theatre? So what do you say to that, Will? Why don't we just take her to theatre and get on with it?
Yeah. Because unfortunately for her, it's not really just a stoma. She's someone who's had 8 previous laparotomies down to the significantly distended abdomen. And also the other thing with these Crohn's patients, I mean, which as we've discussed, her CRP is up, and as much as on the CT scan, we're not seeing obvious fistulae. She might as well have like some other fistulizing disease inside, which makes for quite difficult surgery. So you can get collateral damage by just trying to get in and bring up the stoma, and now you're sitting with a patient who's malnourished, inflammatory state, and now sitting with fistula, and it can result in
I'm
bad.
glad you mentioned collateral damage. The first time I heard that was, I think, Americans on CNN trying to wash away that they'd done some, blown up some people they shouldn't have in the Iraq War, and they refer to it as collateral damage. But I do think it's, we cause a lot of collateral damage in redo surgery, especially with fistulizing disease. And, the classic case we'll have is a patient with a bit of TI disease, slight inflammatory mass, nothing too serious. First operation, you go in, they've lost 10 kilograms of weight beforehand, but it's their first operation, and there's a fistula to the duodenum that hasn't been diagnosed. And now all of a sudden, you've got a repair to the duodenum, and in a patient that's had 10 kilograms of weight loss and more like 20% weight loss. And so that's certainly something that's, I'm a bit nervous about repairing the duodenum at the best of times. To do it in someone who's catabolic really doesn't seem like a good idea. So I think that's why we're really pushing this preoperative nutrition, even in the case where this patient's got stoma, is that we can't afford any slip-ups, not to mention the fact that we know in the malnourished, your wound dehiscence rate is high, your wound sepsis rate is high. There are lots of other complications apart from anastomotic leaks. But as colorectal surgeons, really, it's the anastomotic leak that really scares us and really makes us worry. Okay, so is there any data supporting preoperative TPN? Because that's what we're doing for this patient, support it. Anyone aware? Any of you guys in the hot seats?
Okay.
What I'm aware about, it's only few is randomized, most of them is retrospective, and few of them is taken. So the evidence shown that the people that got TP in preoperatively, they're doing well and they decrease first and post-operative complication. There is no study in my mind exactly, but I remember all of them is pretty much retrospective studies.
So there is a study, a very good study actually, done in the 80s. I think it's in the Lancet with NEJM, that randomized a big group of patients. As I recall, about 200 patients that with preoperative malnutrition to TPN versus no TPN. And there was no difference in the group except there was line-related problems in the TPN group, and they didn't do any better. So that really killed preoperative TPN for decades. When they did a subgroup analysis of those patients, which, you know, now they're not powered to do a subgroup analysis, so that just asks another question when you do a subgroup analysis. It doesn't say, well, the conclusion of the study is this. So, you know, you set out your aim of the study and you powered on your primary aim. And they set there out, does TPN for these patients improve outcomes? And it didn't improve outcomes. So that's the result of the study. But in subgroup analysis, it did say that patients with profound malnutrition seem to do better. And so if you've got profound malnutrition, you know, you'd have to redo the study for that. I think, you know, in these Crohn's patients, you know, someone like this, where they're so severely malnourished, it's, you know, we're not really, it gets quite difficult to do a randomized controlled trial, because I think very few people will be prepared to not give TPN preoperatively to someone who's essentially starved themselves for the last year. So, you know, there is some data, but it's not great. But I mean, overall, the randomized controlled data for preoperative TPN says there's no role for it. So, but, you know, that was just taking patients. I can't remember the exact entry criteria on the study. I've got it somewhere. If we've got time, I can show it a bit later. So, you know, it's a little bit difficult, because we've got these patients that we're treating in a certain way, and this is not just the way we're treating it. The world has moved to a preoperative hyperelementation of some sort, but it's not on a fantastic data set, and we just don't have really good data to show it. But as has often happened, when things make a lot of sense, people just adopt them. But this is something we're adopting that's got quite serious risks to it, because, as you know, TPN comes with a whole host of problems. Okay. Just while this patient is in hospital, any IBD patient, what other things should they have in the preoperative period would you do for all IBD patients that are coming in with a chance of surgery? Anyone in the room?
Few things. I think they need psychologically prepared for the outcome of their operation, so the psych need to be involved. Second thing, I think, while we've got facility to refer to the stoma sister, the ostomy sister, they need to come and visit them, chat with them regarding the chance to getting a stoma also. So they need to be prepped psychologically that they will get stoma, and they need to be cited. The routine things that they are in a hospital, definitely they need to be in a prophylactic for a DVT and all the complications, because increased risk of DVT.
Those are the things I was thinking. I must say, I think you could probably, not many of us have access to a psychologist, and I think one of the best psychologists around is a stoma therapist. They generally can give you a very good idea whether someone needs help or not. But I think, you know, there's lots of data showing that if patients who end up with emergency stomas without preoperative counseling have much more trouble with their stoma than patients who've had a stoma and who've been told about a stoma before the time. So I think it's very important to have that discussion about a stoma early on, right at the beginning. Patients coming in for a month of treatment, we're not planning to do anything. We're not planning a stoma, but there's a chance. In our unit, if you're having an operation on your colon or small bowel with us, you get cited for a stoma. Firstly, it's a vital part of the consent process. When you go into theatre with a mark on your tummy for a stoma, you can't say no one discussed a stoma with you. Theoretically, I suppose they might not have discussed it, but, you know, it's part of the consent process, I think. And it just means that, and I often tell patients who, you know, we're really, you know, going in, got a cancer, having a right hemicolectomy, young, fit, healthy person, why are you talking about a stoma? It's not plan A, it's not plan B. But if you do enough of this, you'll realize that just going in with 2 plans isn't enough. You need a plan C at least. And so I think it's very important that patients have that, especially IBD patients, have that discussion early, because a lot of Crohn's patients are going to end up with stomas. And a lot of IBD patients end up with stomas, and sometimes those stomas are by far and away the best treatment for them. And if they start off their first event with a stoma, is a hugely negative one, stoma will be hugely negative for them forever. So I think the psychological impact of meeting a stoma therapist beforehand, that this is all a possible plan, is really important. We know that IBD patients are predisposed, are hypercoagulable, so they're predisposed to DVT. So your point on Clexane, etc., is really, really important. And then, what are your feelings about? So you're going to treat sepsis. What are your various ways that you can treat the sepsis if a patient's got? Let me phrase it a different way. If you've got a patient with ileocecal Crohn's and a collection, would you, and some obstructive symptoms, would you perk drain the collection first, or would you operate and drain the collection at surgery? Because the patient's, and we say the patient's going to have surgery, it's been decided for whatever reason, this patient is going to have surgery. What would you do, Zubey?
I think ideally I would like to drain the sepsis before I take the patient to theatre. I mean, if we, in this 2-week window period, where we're optimizing the patient, I think you'd want to do everything as best as possible to try and get the patient in that state. So yes, I would drain the sepsis.
What are the advantages of draining the sepsis?
So you can get on through, yeah, I mean, the patient overall would then do better nutritionally from that side of things as well. From a septic point of view, the patient would do better. And then obviously post-operative, when the patient has had the operation, then can have a little bit of a more definitive procedure if you're thinking about definitive procedures. Yeah, I think the overall outcome will probably be improved.
So I think, I mean, the data shows us that, you know, if you do it, the extent of the, if you perk drain beforehand, the extent of the resection is shorter, smaller. You cut away less bile, which obviously is vital in Crohn's disease, because now you don't know what's inflamed because of pus on the outside versus what's inflamed because of the inflammation on the inside. Your chance of doing a primary anastomosis is significantly increased. I, for one, am not happy to do an anastomosis in an abscess bed. You know, I don't think an abscess is an absolute contraindication to an anastomosis. If you can move the anastomosis elsewhere and do the patients otherwise well, but certainly it's a big warning sign, and so your chance of getting a stoma is higher. And so those have been shown in prospective trials to differ significantly, extent of resection and stoma rate. So I think you should, you know, if you can, you perk drain the patients always. What happens if you can't perk drain a patient? What are your other options?
So ideally, you'd probably just start them on antibiotics up front and see what happens to the collection. You kind of hope that the collection will dissolve or get smaller at least, so that when you do get to definitive surgery, like you say, the outcomes would then obviously be a little bit better and your options would be broader. Yeah, see the perk drain or have antibiotics.
Well, yeah, and then you've got the middle ground is that sometimes they're not happy to perk drain it because it's a bit small, but they'll aspirate it. So the advantages of aspirating is that you get bugs for microbiology, but the reality is mostly in our kind of a line of work, you grow a zoo. But you know, it certainly helps that, and antibiotics I think is more effective than antibiotics on its own. Anything under 5 centimeters in maximum diameter, you've got a chance of sterilizing just with antibiotics. And then there's always, you know, open drainage. So, and not a great one. Look, the reality is we can get a perk drain in just about everything. But if you can get an open drain and you can't get a perk drain, I think that's acceptable. And just let things settle down. I certainly would, if you're treating sepsis like that, even with a perk drain, I'd always try and wait 6 weeks before I operated if we were going to aspirate first, or if we were going to perk drain in any way before that. We often what we can often do with the radiologists is if they really can't get, they really don't want to perk drain, you say, well, what about just going straight through the bowel? Because, you know, that bit's coming out. So as long as they're going through a piece that's coming out anyway, and certainly in the intestinal failure practice, we have patients that you just perk drain and it doesn't matter whether you go through bowel, it's not coming out, because we can't do a laparotomy on those patients. So I don't have a major problem. Look, I don't like radiologists to go through the bowel on their own, but if they're doing it in conjunction and shared decision-making, I think it's a very reasonable way to go. Okay, so how are we doing? I see we've got one question here in the chat. Is there a role for low residue diet in this case? So I think that in patients who are cramping a bit but don't have massively dilated bowel, a low residue diet is a thing, and that's where we talk about supplements often. And patients can have exclusive enteral nutrition without taking any, without a nasogastric tube. They don't necessarily need a nasogastric tube, and essentially then you do have a low residue diet. Although there isn't much data saying that patients do better with an elemental diet versus a semi-elemental versus a polymeric diet. They kind of, all of them get you the same effect of exclusive enteral nutrition. But if some are better tolerated from a cramping point of view, clearly if you've got a very narrow stricture, you don't want bulky content with lots of fiber going through that. So I think that that's, I think in general, by the time you're needing a low residue diet to control your cramping, you're probably going to be needing a nasogastric tube. And our experience, although certainly not uniform, but our experience is that if you're going to do exclusive enteral nutrition, you almost exclusively have to do it in hospital with a nasogastric tube. It's by the time someone's just taking some supplements, they never just have the supplements. They always go home and have some of the stew that everyone else is having or whatever it is, and it doesn't seem to work as well. The other problem we have is that exclusive enteral nutrition does actually seem to work really well, and the patients often stop cramping, their abdomens deflate, and they're doing a lot better on exclusive enteral nutrition, and then they discharge themselves. And by the time they come back again, they've lost 10 kilograms of weight, and we start the whole cycle again. And so I think you need to prepare patients to say, look, you're sick now, this is going to make you a bit better, but it's not going to make you better in the long term. We're planning surgery, that's the decision. It might be that surgery is the wrong decision and that you're going to induce remission and then treat them. But often, we're in situations like this where we don't have any further treatment options. And even if you gave them steroids and they got better, what would you do after the steroids? You can't keep patients on steroids forever. Are there any other questions from the audience? Kind of getting close to an hour now. I see we've got a couple of medical gastroenterology fellows. Cecilia, Thania, anyone else with a question? Is anyone else doing preoperative hyperelementation for Crohn's disease? I suppose you've got to ask how much Crohn's disease is everyone else seeing. So we certainly don't do this very much for, so we've got a question here, can we operate when patients on steroids? Well, if you have to operate, you've got to operate. I mean, if there's a patient with an indication, an acute abdomen, severe sepsis, then you've got to go ahead. But I would certainly try not to operate the patient on steroids. And my chance of doing an anastomosis with a patient on steroids is pretty close to zero. I think under 10 milligrams per day of prednisone, a lot of people would say you can consider doing an anastomosis. Our anastomotic leak rate in general for elective surgery is about 15%, and I'm not keen on raising it. So generally for us, on steroids, you're not going to get an anastomosis. So, I mean, I think there are absolute indications for surgery. You can't do hyperelementation and preoperative optimization on everyone. Patients got an acute abdomen, you've got to go for it. The patient's bleeding, you've got to go for it. But if you can wait, you can. Next question, biologics before surgery. So once again, if you've got, the data on biologics is very variable. There's data showing that you can operate after biologics, and it makes no difference to your perioperative outcomes, and there's data showing they have worse outcomes. Most surgeons that do a lot of IBD surgery will talk about the odd patient they've had where everything has just fallen apart terribly after biologics, and the patient's done really, really badly. And I suspect that there's probably a group of patients on biologics that do really badly, and I'm not sure what they are. There's a limited amount of data showing sort of timing between biologics, that the further away from the biologic you can get, the better the outcomes are, and that it's dose dependent. So if your levels of biologic are very high, you have a worse outcome. But I don't think that that's really been yeah, I'm not sure that it's certainly it's very sort of preliminary data. So, I would generally try and wait as long as we can. Patient that's failed biologics, there's no urgent indication to operate. Let's see if we can push it out a little bit before doing that. But if you have to, you have to. It's certainly not an absolute contraindications. See, Colin has written a thing about the preoperative anemia. And so it's linked to worse outcomes in terms of morbidity and mortality, with transfusion being an independent variable. Transfusion also linked to worse 30-day mortality, as mentioned, though. No randomized controlled trials to date showing restoration of anemia preoperatively is linked to better outcomes. 4 RCTs on the way at the moment, most in cardiac surgery. Yeah, and I think that's cardiac surgery. Obviously, they have a real quite high transfusion requirements. We tend to have very low transfusion requirements. Cecilia's asked, if a patient is like this, has failed medical therapy, what would the next step be if defunctioning diverting stoma fails to control symptoms disease? I don't know. At some point, I mean, there's a group of patients that end up on TPN, and home TPN is an indication for it. Claire's got a hand up. So I saw a camera.
Cool.
Hi, Claire.
Thanks. How's it, Adam? Good talk. Basically, what Colin said, there's a great summary of what you said. You could just take out anemia there and put pre-op nutrition. I mean, if you look at the Cochrane review, which was done ages ago, but unfortunately still holds, the data is from 20 years ago, as you said. We know that patients who've got poor pre-op nutrition do badly. And we've got no evidence that if we try to do something about that nutrition pre-op, that the data gets any better or the patients do any better. So I think it's pretty much the same.
Yeah, I mean, it is exactly the same with anemia. I mean, it's the same with albumin, the same with nutrition, the same with anemia. We don't know. But, what happens is these things end up becoming the standard of care with a lack of data. Unfortunately, in preoperative nutrition, there aren't 4 randomized controlled trials recruiting at the moment. There are exactly none.
Room for us to do something.
It gets to a point where it becomes such common practice that it becomes unethical to test it, which, we could say the same thing about total mesorectal excision. You couldn't randomize that now. So, all right, last comments from anyone? Vu, Zubair, and Mohammed in the hot seats there. Any comments?
No, we just had a response to Cecilia's question that if the defunction doesn't work, we'll be referring the patient
to them. Yeah, fair enough. All right. So I think if there are no further questions, anyone got anything? I'd just like to say thanks to the presenters, thanks to Vu and guys in the hot seat. Always difficult to get asked questions in a public forum, but I think you did well. And thanks to ECHO and the University of New Mexico and the ECHO India team for the support. Apparently there's a feedback form available in the chat. Recordings will also be available on the Gastro Foundation website. And thanks to the Gastro Foundation. And next week on the 14th of March, treatment of pancreatic adenocarcinoma, and that'll be Martin Brand will be telling us about that. Okay, so guys, thank you very much. And thanks once again to the Curtis-Q fellows. Let's see if we can get some of the other fellows from around the country. I'll be coming for you next. Okay. Cheers, guys. Thanks very much.
Thanks, Adam. Cheers.